Well, good afternoon, everybody. My name is Holly Cox, and I'm with the Center for Public Safety and Wellbeing, which is a continuing education unit at Wilfrid Laurier University. If some of you have taken courses with us before, you may have communicated with Elise Kirby, who's also with the center, and she's here with us today too. I'd like to start today by acknowledging that Wilfrid Laurier University and its campuses are located on the Haldeman Tract, which is the traditional territory of the neutral Anishinaabe and Haudenosaunee people. This land is part of the Dishwath-Montespoon Treaty between the Haudenosaunee and Anishinaabe peoples and symbolizes the agreement to share and protect our resources and not to engage in conflict. So today we are welcoming the HIV Legal Network, who will inform us about the science, public health, and human rights implications of HIV and hepatitis C virus as it relates to the provision of policing services. So we have two presenters with us today. India Annamanthadu is a lawyer and policy analyst with the HIV Legal Network. At the Legal Network, her work focuses on HIV criminalization, drug policy, and challenging anti-LGBTQ laws in the Caribbean. Joseph Friedman Burley is a research and education consultant with the HIV Legal Network, and his work focuses on advancing health equity for LGBTQ Canadians through community-based research and policy development, specifically in the areas of long-term care, anti-violence, and sexual health. So with that, I will turn it over to India.
Thanks, Holly. Very nice to be here today and to see everyone out. I'm going to pass it on to Joseph, who's going to take us through the first half of the manual, and then I will guide us through the second half. Joseph?
Thanks so much, India, and thanks, Holly, for that warm introduction. So I'm really pleased to be here with all of you today to present on this recently released manual from the HIV Legal Network. It's called Centering Health, Respecting Rights, and it's all about understanding the science, public health, and human rights implications of policing in the context of HIV and hepatitis C. So a bit of an overview about our presentation today. I'll begin by providing some background and context for the project, and then, as India mentioned, I'll provide an overview of part 1 of the manual, which focuses on HIV, HCV, and occupational health and safety. So this is a broad overview of HIV and HCV in Canada, and this section highlights how police can manage occupational safety concerns on the front lines of service provision. I'll then hand it off to India, who will explore part 2 of the manual, which is all about human rights, public health, and the role of police. And this is really about how police can support HIV and HCV prevention efforts in ways that reduce stigma, promote health, and uphold the human rights of priority populations. Following that, we'll open up the floor for a Q&A portion. So I'd first like to provide some context and history for this project. So to equip the police with greater knowledge and the capacity to apply that knowledge in their law enforcement practice, so as to promote access to HIV and HCV and other health, social, and support services, particularly those targeted towards priority populations, the HIV Legal Network embarked on a multi-stage community-based project to develop a training manual to improve the provision of police service to people living with and affected by HIV and HCV. And I'd just like to highlight the term priority populations. So at the Legal Network, we use that term to describe groups who are disproportionately affected by HIV and or HCV. And in Canada, these groups include, but are not limited to, gay, bisexual, and other men who have sex with men, or MSM for short, Indigenous people, people who use drugs, transgender persons, people with experience in the prison environment, and people from countries where HIV and HCV are endemic, as well as sex workers. So this project has been through many, many stages. We started off in 2019, and so we are really, really grateful to be able to present to you on the final product today. Just a little bit of an acknowledgement here. The team who has contributed to this project is very, very large and diverse. We've had a number of incredible key informants from both priority populations and communities, as well as police representatives. And so I'd just like to say a big thank you to everyone who has been involved in getting this manual to where it is today. So I'll begin the session today by providing an overview of the first section of the manual, which explores HIV, HCV, and occupational health and safety. You'll also notice in the manual that each section begins with a set of learning objectives, and these outline key knowledge and takeaways for learners. The objectives in both sections were derived from our review of the scientific literature and developed with key input from our police and community stakeholders. So as you'll see on the slide, there are 6 learning objectives in section 1. The first is to identify the biological and virological foundations of HIV and HCV, including transmission, symptoms, progression, and the differences between HIV and AIDS. We then explore the current epidemiology of HIV and HCV in Canada, including their impacts on priority populations. In this part, we also identify Indigenous people as a priority population whose HIV risk is shaped specifically by Canada's legacy and the ongoing impacts of settler colonialism. We then examine up-to-date information on treatment and prevention, including antiretroviral therapy or ARVs, direct-acting antivirals or DAAs, pre-exposure prophylaxis or PrEP, and post-exposure prophylaxis or PEP. Then we highlight the various routes of HIV and HCV transmission, and we emphasize those routes that officers are likely or may encounter in occupational settings. We then identify universal precautions that officers can use to prevent risk and infections on the job. And we conclude by examining post-exposure protocols and appropriate follow-up procedures. And while we don't have time to go into all of these learning objectives today, I will highlight some important information and key takeaways from this section. So without going into too much detail here, you'll see that this slide gives an overview of what is covered in the first part of this section. It's basically a kind of 101 crash course that encompasses key information on HIV and HCV, including symptoms and how both diseases progress, as well as how they're transmitted, treated, and prevented. And just to emphasize and kind of flag here, knowledge about HIV and HCV can really help enhance occupational safety during frontline service provision for police officers. It can also prevent police from contributing to the spread of misinformation and stigma through their professional practice. When engaging people living with or affected by HIV and or HCV, it's really important to remember what you know about risk, transmission, and stigma and conduct yourselves accordingly. In light of that, there are 2 key pieces of information that I want to highlight here. So the first relates to HIV treatment. At present, there is no known cure for HIV. However, people living with HIV can take antiretroviral medications, or ARVs for short. And these medications inhibit the virus's ability to replicate in the body, reduce symptoms, and then enable people living with HIV to lead long and healthy lives. ARVs not only reduce the amount of virus in the body, but also lower the risk of HIV transmission to others. And a person living with HIV who remains on treatment for a sustained period can suppress the virus to such an extent that HIV becomes undetectable in the blood. And that term, undetectable, refers to the fact that the viral load in their blood is so low that it cannot even be detected by conventional HIV testing technology. And that finding, and a person with an undetectable viral load is actually effectively incapable of transmitting the virus to others. And that scientific finding has spurred the popular undetectable equals untransmittable, or U equals U movement. The second thing I want to highlight is about HIV prevention. So first, a lot of HIV prevention happens at the individual or behavioral level. So these are things like using a condom or sterile injection equipment, which we know minimize the risk of transmission of HIV. Just as important are public health policies and programs that promote access to those vital prevention resources and educate people about HIV risk. And the same thing can be said for hepatitis C. We need knowledge and education around how HCV is transmitted and access to things like sterile injection equipment so that folks can reduce their own risk at a kind of individual or behavioral level. However, we want to flag that with HIV specifically, there are 2 important prophylactic medications people can take to drastically reduce their risk. The first is pre-exposure prophylaxis, or PrEP. PrEP is an everyday oral medication that is taken before exposure to HIV. So that's where the pre comes from. When someone on PrEP is exposed to HIV, the medicines counteract the virus and prevent the establishment of a permanent infection. When taken daily, PrEP reduces the risk of acquiring HIV by about 99%, so it is an incredibly effective prophylactic medication. The second medication is called PEP, or post-exposure prophylaxis. And this refers to treatment with antiretroviral therapies immediately following exposure to HIV. So it's after exposure, and that's where the kind of post comes from. PEP is used primarily in emergency scenarios and must be taken within 72 hours of initial exposure to HIV. And during that 72-hour period, time is really critical. The sooner you get on PEP, the more effective the treatment will be at preventing transmission. The other thing I want to flag is that this section of the manual works to dispel some very common and very stigmatizing myths and misconceptions about HIV and HCV. So as you can see on the slide, HIV and HCV are not spread through casual social contact. So you cannot contract these viruses from hugging or kissing or shaking hands. Unlike COVID-19, which I know is top of mind for everyone these days, HIV and HCV are not spread like the common cold or flu or other respiratory viruses. So you cannot catch these viruses from someone coughing or sneezing or breathing in your vicinity. You also cannot contract HIV or HCV from sharing utensils or a toilet seat. HIV and HCV cannot be transmitted through saliva, tears, sweat, urine, feces, or vomit. And lastly, we spend some time to distinguish between HIV and AIDS. And while these terms are sometimes used interchangeably, that is actually incorrect, as there are key differences between HIV and AIDS. To clarify, HIV and AIDS, although related, are entirely different conditions. So if left untreated, HIV can develop into AIDS at a later stage of the virus's progression. But with increased access to effective ARVs in many parts of Canada, it is highly unlikely that someone diagnosed with HIV would remain untreated for so long that they will develop AIDS. In fact, recent data indicate that 85% of people in Canada diagnosed with HIV are on treatment. Further, AIDS is not the virus that is transmitted between people, HIV is. So it is rarely, if ever, accurate or appropriate to use the term AIDS in relation to someone living with or transmitting HIV. And doing so can really reinforce harmful misinformation and stigma. This section also discusses the epidemiology of HIV and HCV in Canada, which means that we look at the number of cases nationally and examine how those cases are distributed among various priority populations. So here on the slide, you see a figure representing the estimated number and percentage of persons living with HIV diagnosed, on treatment, and virally suppressed in Canada at the end of 2018. This graph indicates that as of 2018, there were about 62,000 people living with HIV in Canada, and of those, 87% had received a diagnosis. Additionally, 85% of those diagnosed were on treatment, and 94% of those on treatment were virally suppressed. So it's important to remember that these 43,000 Canadians who are virally suppressed pose very, very little to virtually no risk of transmitting the virus to someone else. This section then examines how HIV and HCV impact priority populations. And remember, when we use the term priority populations, we mean groups who are disproportionately affected by HIV and HCV in Canada. But what does it actually look like to be disproportionately affected by HIV and HCV? Below, we provide some key examples. So as you'll see on the slide, in 2018, the Public Health Agency of Canada estimated that about half of all new HIV cases were reported among gay, bisexual, and other men who have sex with men, despite the fact that this group accounts for a mere 3 to 4% of the adult male population. Indigenous people, and Indigenous women specifically, also continue to be overrepresented in the HIV epidemic in Canada. An estimated 14% of all new infections in 2018 were diagnosed among Indigenous people, whereas this group represents only 4.9% of the total population in Canada. Additionally, in 2018, 43% of federal prisoners living with HIV were of Indigenous ancestry, and HIV prevalence was higher among Indigenous prisoners compared to those with non-Indigenous ancestry. While population-level data around HCV are a little harder to find, we do cite a key 2011 study that indicates that 24% of federal prisoners and 23.3% of provincial prisoners were antibody positive for hepatitis C. And this stands in stark contrast to the mere 0.64% of the general population. So this slide gives a little overview of how HIV and HCV impact priority populations. And in a couple of minutes, my colleague India will kind of explore why these disparities might exist, taking a public health and social determinants of health lens to do that. The first section of the manual concludes with an overview of HIV and HCV in occupational health settings, particularly in the context of frontline police service. We emphasize that while there is plausible risk of contracting HIV or HCV on the front lines through contact with blood or other body fluids, occupational transmission is exceedingly rare, and to our knowledge, there is no documented evidence of HIV transmission to a police officer in Canada while on the job. Nonetheless, this section explores the three most commonly cited potential sources of occupational transmission for police officers and provides hard facts and evidence about risk. So the first potential route of transmission or exposure is needle stick injury, or NSI. It is theoretically possible for someone to contract HIV or HCV if their skin is punctured by a needle that has been recently used by someone who is HIV or HCV positive, but the actual rates of transmission are exceedingly low. For one, HIV is a very fragile virus. It's incredibly sensitive to temperature and light, and so it is virtually incapable of surviving outside the body. That means that dried blood on a discarded or used needle is very unlikely to pose any risk for HIV transmission. Second, while a recently used needle stored on a person can puncture an officer's skin during a body search, there are precautions that can be taken to avoid such risk. Studies have shown that the average risk of HIV infection following a needle stick injury is about 0.3%, or 1 in 300 cases. The average risk for HCV infection following an NSI is approximately 1.8%. Regardless, it is always a good idea to seek medical attention immediately following a needle stick injury. The second route of exposure, or potential route of exposure, we explore is biting. So the likelihood that HIV would be transmitted through a bite, where the person doing the biting had a significant amount of blood in their saliva, and their blood came into contact with a mucous membrane or open wound, and their viral load was unsuppressed, that risk varies from negligible to none. In any case, if a person is bitten on the job, and especially if the bite draws blood, they should seek medical attention immediately. The third and final route of potential exposure that we explore is blood in the mouth or eyes. So it is hypothetically possible for HIV or HCV to penetrate the mucous membranes in the mouth or eyes and cause infection, let's say during an agitated physical altercation, or perhaps if an officer is performing mouth-to-mouth resuscitation on someone who is living with HIV or HCV. A medical risk assessment should always be sought after either of these incidents, but on average, the risk of contracting HIV following exposure of the eyes or mouth to blood is estimated to be 0.1%, or 1 in 1,000 cases. The risk for contracting HCV is unknown, but also expected to be very, very low. This section concludes by emphasizing the importance of universal precautions to reduce risk on the job. These are things like always wearing gloves at crime scenes or during body searches, making sure any wounds or sores are bandaged before service, and using protective devices when performing mouth-to-mouth, including wearing other important PPE, whenever you're providing police service. These precautions should be followed whether or not officers are working with someone who they know or suspect to be living with HIV or HCV. Remember, there is no need to engage in extra precautionary measures when working with someone who you suspect might be living with HIV or HCV, and doing so can spread public misinformation and contribute to stigma. So if you're working with someone who you suspect might be HIV or HCV positive, there is no need for you to wear 15 pairs of gloves and 3 extra masks. And doing that kind of thing can really stigmatize that person and contribute to misinformation about how HIV or HCV are spread. However, we do understand that needle stick injuries are a big concern for frontline officers, and so include a best practice guide on safe body searches from the UN Office on Drugs and Crime. Finally, we touch on post-exposure protocols, exploring what steps officers can take if they feel they've been potentially exposed on the job via blood body fluids, or needle stick injuries. We reiterate that anyone concerned about HIV or HCV risk should be regularly tested, and that the decision to administer post-exposure prophylaxis or PEP, while very, very rare for occupational HIV or HCV exposure, those decisions are made on a case-by-case basis through consultation with a licensed healthcare provider. So with that, I'll hand it off to India to present on part 2 of the manual.
Thanks, Joseph. Appreciate that really thorough and interesting overview of the biology of HIV and HCV. And now I'm going to take us through part 2 of the manual, which is focused on the human rights, public health, and the role of police. Next slide. So there are 3 main learning objectives associated with this part of the manual. The first is to explore how social determinants of health impact HIV and HCV risk among priority populations. The second is to define the laws that uphold and undermine the human rights and health of these groups. And the third is to identify police practices that can better respect the health and human rights of these groups. Today, I'm mainly going to be touching on 1 and 3. But just to note that learning objective 2 is explored in greater detail in the manual, and you can refer to it if that's something that you're interested in learning more about. Next slide. I'm going to start off our discussion today by talking about social determinants of health. So as you'll recall from Joseph's presentation, there are certain priority populations which represent a disproportionate amount of Canada's HIV and HCV cases. As you recall, this includes men who have sex with men, people who use drugs, sex workers, people who are incarcerated, Indigenous people, trans people, and women and youth among these populations. So why is it that these groups are disproportionately affected by HIV? We know that it's not a matter of genetics or biology, but what is it that makes these groups priority? And to explain that, we need to look at the concept of social determinants of health. Social determinants of health are socioeconomic factors that influence someone's health. In other words, they are the conditions in which people are born, grow, work, live, and age, which influence someone's health outcomes. For HIV specifically, social determinants of health can look like poverty, education, housing stability, barriers to accessing healthcare, stigma and social exclusion, as well as historical traumas like colonialism. And often when we talk about HIV risk, we talk about factors at the individual level, like engaging in unsafe injection practices or higher risk sex. But these really only form a part of the picture. The manual helps to explain some of the larger upstream forces that influence people to engage in these behaviors. And the interesting thing to note here is that social determinants of health often are more important or just as important as other factors in determining someone's health, like quality of healthcare or lifestyle choices. And in the case of HIV, social determinants of health can influence whether someone can access HIV testing, prevention, or treatment, all of which impact a group's vulnerability to HIV. So in other words, a priority population is considered priority because they experience socioeconomic conditions which increase their vulnerability to HIV and HCV throughout their lives. Next slide. I'm going to start off by just talking about HIV stigma, which is a social determinant of health that is frequently reported by all priority populations. And HIV stigma refers to negative attitudes and beliefs that are held about people living with or affected by HIV. Now, you may think that HIV stigma was a thing that we left in the 90s, but it's very clear from the stats that this is something that's ongoing even today. I've put up some stats on attitudinal behaviors around HIV that were collected by the Public Health Agency of Canada. And just read out one, that 24% of people in Canada feel uncomfortable wearing a sweater once worn by a person living with HIV. Even though we just learned from Joseph's presentation that HIV is an extremely fragile virus that can't be passed through surfaces outside the body, or very rarely at least. So I think these stats just highlight how prevalent HIV stigma continues to be in Canada. And the really dangerous thing about HIV stigma is that it can lead to discrimination and social exclusion and isolation. People living with HIV often report being treated like garbage in many social interactions throughout their life. They also may experience internalized stigma and shame as a result of this external stigma. All of these factors can lead to people avoiding seeking HIV testing, prevention, and treatment for fear of being mistreated or judged. In turn, all of these factors increase someone's risk to HIV. So I think that quote I have on the slide here from a person living with HIV who injects drugs illustrates what stigma feels like for someone in these situations. They said, a lot of people don't even tell their families about their HIV status because of fear of being judged. So that can discourage people from disclosing and getting the proper supports and help that they need. Next slide. A second determinant of health, which affects all priority populations, is barriers in accessing healthcare. When there are barriers to accessing healthcare, the risk of HIV and HCV infection increases among priority populations. So one example of a barrier to accessing healthcare that we frequently see is prejudice and discrimination, as well as homophobia, sexism, racism within the healthcare system, which can prevent people from accessing this care. As you'll see on that top quote on the slide, a person living with HIV said that when the doctor came into the room, the doctor had on 3 pairs of gloves, and yet it wasn't even a problem related to that person's HIV status. This goes back to what Joseph was saying about, unnecessarily putting on masks and gloves when you're dealing with a person you suspect is living with HIV can be really stigmatizing and make them not want to access that service. Sorry, if you can just go back, Joseph. So another barrier to accessing healthcare that's experienced by these priority populations is a lack of physical access or specific programming. So when we talk about a lack of physical access, it could be a lack of geographical access. Like for instance, if you live in a remote community or you live on reserve and the nearest HIV testing center is a really far distance away. That shows a lack of physical access and a barrier to accessing healthcare. It can also mean in terms of lack of physical access or programming in specific settings. So for instance, one that I'd like to highlight is for people who are incarcerated, which we've identified as a priority population. So people who are incarcerated have an increased risk of HIV and HCV transmission because they lack access to sterile injection equipment and other harm reduction measures. And when people lack an access to sterile injection equipment, it's not that they don't use substances, it's just that they'll share equipment, increasing that risk of HIV and HCV transmission. So if we only consider the high risk behavior here of using unsterile equipment, we'd be missing the bigger picture, right? The forces that push people into those behaviors. And in this case, it would be a lack of access to sterile injection equipment. And that quote I have on the slide, and the second one there, highlights this. This person who was formerly incarcerated said that stores wouldn't sell them needles because they look like a junkie, and then you would go and use somebody else's needle. Next slide. And before I cap off this discussion of social determinants of health, I really want to highlight Indigenous people as an important priority population to discuss. So I've listed a few determinants of health that are specific to Indigenous people in Canada, which include settler colonialism, anti-Indigenous racism and discrimination, the reserve system, forcible displacement, residential school systems. All of these factors contribute to the widespread health inequities we see in Indigenous people generally, and when we talk about HIV. In this discussion of social determinants of health, I think it's important that we also are mindful that we don't perpetuate a narrative of helpless victimhood of these priority groups. It's really important that we also highlight HIV resiliency. Despite all of these structural factors, priority populations are resilient, they're tenacious, and they're optimistic. This quote I have on the slide, I think does a good job of highlighting just how resilient these groups are. This woman living with HIV said that we have a lot to face. And at the end of the day, we sit, we feel depressed, we feel bad, but we have children to look after, send them off to school, some of us to work. So we get up, we face the day like nothing is going on, although we're hurting inside. I think that's our greatest strength. Next slide. Okay, so the next section in the manual is about HIV and human rights, and it highlights laws that protect the human rights of people living with or affected by HIV and HCV, and laws that undermine the human rights of these groups. I won't get into detail, but just to say that there are a variety of legislation that impact police's ability to provide services, and that police need to consider when providing services in order to make sure that their service provision is upholding the right to freedom from discrimination for these groups. As well, there are a number of laws that are relevant to police in the provision of services, including the criminalization of HIV non-disclosure, drug use, and sex work, which I would highly encourage police officers to read these sections to gain more understanding about. Next slide. Okay, so now that we've talked about social determinants of health and why certain communities are priority populations, I'm going to outline some practices that police can employ to better respect the health and human rights of these groups. And in the manual, we've touched on 3 practice guidelines. So next slide. The first practice guideline is to exercise discretionary enforcement to minimize the negative impact of police contact. We know that police discretion is a very powerful tool, and that the exercise of discretionary enforcement, especially one unguided, has been used to contribute to the disparate arrest and charging of Black and other racialized communities. But in the case of HIV, police can use this discretion to minimize contact with priority populations in a way that reduces the impact of policing on these people's access to HIV and HIV services. Particularly, this is the case when we're talking about police interactions as it relates to drug possession and sex work. So I've got a couple examples on the slide of ways that police could implement discretionary enforcement. The first is to use your discretion to not confiscate drugs or drug use equipment, because we know, as I mentioned in previous slides, that when people do not have access to their equipment, they'll just end up sharing equipment with somebody else. It doesn't actually prevent them from using substances generally. So this in turn will increase somebody's risk of HIV and HCV. Another potential way to implement discretionary enforcement is to not attend overdose sites unless your presence is required because of a security threat. Our work with communities has revealed that when police attend to the scene of an overdose and they're not needed, and they come and they question people at the scene, this can actually prevent people from calling 911 the next time that they experience an overdose. Another potential way to implement discretionary enforcement is to not engage in aggressive surveillance and arrest. In sex work, we've heard from our sex work colleagues that police will sometimes flash their high beams at sex workers or call them names when they're working in public spaces. And this just serves to push sex workers into more dangerous and isolated conditions, which increases their vulnerability to HIV and HCV. In the context of supervised consumption sites, we've heard from people who use drugs that when police patrol supervised consumption sites, it actually deters people from accessing these really important life-saving services. Finally, the last thing I want to touch on is that if police do make an arrest of somebody who's living with HIV or HCV, it's really critical that we take time to think about whether the release of their personal health information is necessary. This is information that once it's out can never be put back. And as I've talked about, HIV is a highly stigmatized condition, so much so to the point that many people who live with HIV haven't told close family or friends about their HIV status. And so by police releasing this information, you can actually be outing people to their community. I've heard of examples where people have experienced great harms because of police release of HIV status, leading to them actually have to move out of their community and lose their job. Next slide. The second practice guideline that the manual touches on is to reduce stigmatizing language and behavior when interacting with people living with or affected by HIV and HCV. There are numerous outdated and harmful terms that we have here on the slides that should be avoided. because these terms can reinforce stigma and increase vulnerability to HIV and HCV. When we use language that's appropriate, we are upholding the rights of these groups to be free from discrimination, and we're reinforcing and emphasizing their dignity and equality. So you'll see on the slide that there are terms to use and terms to avoid. And you'll notice with the terms to use that they're often person first language. So they put the person before the condition or the characteristic. And one example, you've heard Joseph and I use this. We use people living with HIV rather than HIV carrier or HIV infected, or worse, AIDS carrier, because as you know, AIDS is not a condition that you can infect people with. It's HIV. So those are some terms, I think this is a really great resource in the manual for just trying to use better person first language. But ultimately, the bottom line here is that people should be referred to by the terms that they prefer. Next slide. The third and final practice guideline in the manual is to incorporate cultural safety into service delivery to Indigenous peoples and other priority populations. I've included a diagram here that's from the manual about the spectrum of cultural safety, which includes cultural awareness, sensitivity, and competency. And in the context of policing, cultural safety could include communicating clearly, respecting differences in cultures and values, avoiding harmful stereotypes and stigmatizing language, as we just touched on. And importantly, recognizing that everyone has a unique history and set of experience in interacting with law enforcement, and that this might impact their engagement with you, particularly for Indigenous people who have a long, long history of experiencing policing harms. One way, for example, to implement cultural safety could be to engage with Indigenous community members on the best service delivery, design, and evaluation. The bottom line here, though, is that cultural safety is about engaging with priority populations in a way that is self-reflective, engaged, and compassionate. And ultimately, improving cultural safety will improve the delivery of services to the communities that you're working with. Next slide. So I'm going to pass it back to Joseph now to take us through the end, and then we'll open it up for discussion.
So before we open the floor for discussion, I just wanted to finish off by highlighting one of the appendices in the manual. So these are the end sections of the manual. And we want to focus specifically on Appendix C, which provides some guidelines for the implementation and the uptake of the training. So this appendix is really intended for use by police officers or those in leadership positions who wish to improve training among their staff or in their respective divisions. The appendix draws heavily on the principles of the trans-contextual model for autonomous motivation, which is a theory used to promote behavior change from adult education initiatives. It also draws heavily on the philosophy of community policing. So the appendix will help officers apply what they've learned in practice by training colleagues and advocating for and implementing concrete organizational changes. And to do this, the appendix is divided into two sections. The first section explores the core components of the trans-contextual model and helps senior officers increase autonomous motivation on the part of their colleagues to implement what they've learned from the manual into their delivery of police service. So it really helps take the content off the page and help folks embody what they've learned and apply it in practice. And then the second section provides some suggestions to create organizational environments that support officers in modifying their practice in ways that promote community policing and enhance the access of priority populations to health and social services. So without going into too much detail here, this is a really great resource for anyone who reads the manual who wants to take their learning to the next level and start to affect change in the way their colleagues practice policing service and the way their organizations respond to the needs of priority populations. So anyone who really enjoyed the manual and wants to see broader change from the kind of independent learning they've done should definitely explore this resource. So with that, thank you all so much for hearing us out. We really appreciate your time and interest. and we will open the floor for questions and discussion.